making your weekend a productive one by being a part of this conference. I am Aisha Rehan, President VFORT National Council, and I welcome you all to this session of the Future of Dentistry International Virtual Dental Conference 2020. With me, I have Dr. Kashif Hafeez. He is the Honorary Clinical Teaching Fellow at the University College London Eastman Dental Institute. Great to have you on board, sir.
Thank you very much. So can you guys hear me?
Yes,
Okay. So,
duration of this session.
yeah, I'm live and
Okay.
you can hear me, all right? Okay,
Yes,
perfect.
I can hear you perfectly. So
Perfect.
the duration of this session is going to be 45 minutes. When there's 15
Okay,
minutes
perfect.
remaining, I'll ring the bell like this, and you can
Okay, perfect.
know that 15 minutes are remaining. I'll ring the second bell when
Okay.
10 minutes are remaining, and the last bell will indicate that the session is to be concluded.
Okay, perfect. There are too many bells
All
though.
right.
Okay.
Okay. Okay, sir. I'll hand over the
Okay.
session to you.
Okay, thank you very much. Good morning, guys. It's nice and bright in Oxford, and I welcome you to this amazing conference hosted by some amazing people and organizers. They have put quite a lot of effort onto it, and I think that they should have some applause for putting that hard work into it. This virtual world is new to us in dentistry and in our everyday life now, as COVID has hit us, and so everybody is stuck at home, and we are pretty much online. We're doing everything online. In England, we have started doing online consultations as well, and so the world has changed. But welcome you all. A bit about myself. I am the dental ambassador for Southwest England Royal College of Surgeons, Edinburgh as well. I did my graduation proudly from Pakistan, and later on I did my membership from Royal College of Surgeons, Ireland, and did my fellowship from Royal College of Surgeons, Ireland. I did my fellowship from Royal College of Surgeons, Edinburgh as well. And due to my passion in teaching and training, I did my postgraduate certificate in medical education as well from Oxford. And to continue with the teaching and training, I did my fellowship in dental training faculty from Royal College of Surgeons, Edinburgh. And to close it off, I did my postgraduate certificate in mentoring and coaching and leadership. We have got a boom of mentoring and coaching in England, and it's quite beneficial for the newcomers, for the new dentists who are being introduced into the dental world, so they can share their questions with their mentors, and mentors can share their knowledge with them. So it's quite interesting then that when we mentee our students, then we can share our knowledge and share our experience, and that's on-job learning as well. So they learn while they are doing the work. So it's a very good way of sharing knowledge and training nowadays. I think that has to be, I think primarily the audience in this conference is from Pakistan. So primarily, I would suggest that we should introduce that concept in Pakistan, which is already taking place. There are quite respected seniors and quite experienced clinicians in Pakistan who have got inducted training in their training programs and training in the training programs. So they actually are doing quite a lot of mentoring, but it has to be a bit more structured. It has to be a bit more organized. So we can talk about it at some level.
Excuse me, Dr. Kashif? Yeah, I can't hear you. There's something wrong with your mic. We can't hear you.
Can you hear me now?
Yeah. Now it's fixed. Thank
Okay.
you.
So you've not been hearing me all the time. Okay. So there's an increasing trend of this world digital in every aspect of dentistry. It's implant dentistry, it's restorative, it's every aspect of dentistry that has been overwhelmed by this word. It is quite appealing. It is quite attractive, and it can attract quite a lot of new dentists towards it. But my plea to you is you should be focusing on the basics. That's the most important advice I can give you for today. Don't forget your basics. Yes, digital implant dentistry or digital dentistry in every aspect of dentistry has got its place, but you need to know your basics. That is the foremost of dentistry. So we're going to talk about a bit of basics today. We're going to talk about a bit of digital today, and we'll talk about different cases as well. But again, the main message is going to be: do not be deviated from your basic skills. These are very important, and that should be manifested in all of your treatment plans, in all of your treatments, what you're executing. Okay, so once again, thank you organizers for putting down such a good conference and such a great effort. So initiative of this conference is quite great. We need the future of dentistry and infection prevention. I'll be speaking to you guys tomorrow as well for the infection prevention and control aspect in dentistry. So keep logged in. Now, implant dentistry is booming, and as more and more dentists are providing this way of treatment, there are more treatments available. The patients have avenues to go, but at the same time, the patients are suffering as well. There are more cases which are being unsuccessful, which are failing. So we need to keep an eye on that as well. If the spectrum is quite broad, then there can be mistakes as well. So it's like any other thing which is affecting the common public or population. Failure in implant dentistry is debated in the Parliament houses in England as well. So and these are the statements that come, or these are the things that come out of that debate in the Parliament. We need to be aware of the guidelines. That is very important. There are guidelines which are available, the international guidelines which people are following, and they are delivering good results. But if we do not follow the guidelines, then we will make mistakes. So the guidelines have to be followed, and the bone loss around the implant is actually a time bomb, which is a mystery to us, which we do not want, but yet it happens. And there are so many cases which are being done in England, across the world, in Pakistan as well. So there are so many cases which are being done, but so many neglect as well. Baroness Gardner of Park's a conservative peer and a former dentist. She admitted that she has been unaware of the threat posed by peri-implantitis. That's a big word for dentists all around the world nowadays, for implant dentists all around the world nowadays. And some studies suggest that 1/3 of implant patients will be affected with this. So imagine, out of 3 implants, 1 implant is going to have peri-implantitis. That is a very, very big risk, or very big aspect of implant dentistry we look into. We need to keep an eye on the factors that will introduce, or that will influence, or that will initiate the peri-implantitis. So that has to be taken into consideration when you are planning a case for implant dentistry. And she is comparing actually the dangers posed in implant dentistry to the cheap silicone French breast implants, which later had to be removed. There are quite a lot of patients who actually underwent surgery to get them removed. So, and similarly, this happens in implant dentistry as well, that when you're going to have bone loss around your implant, peri-implantitis, it's out. We know from inner heart, we know if peri-implantitis has started, the implant has to come out or will come out. So it's a very, very big challenge nowadays for all the implant dentists, for all the dentists who are placing implants and involved in implant dentistry all around the world. And similarly, when there are more cases which are being unsuccessful, then the lawyers, the solicitors, unfortunately, will come in. And when the solicitors are going to come in, the General Dental Council has admitted that there has been an increasing number of complaints regarding peri-implantitis or damage to the bone tissues and surrounding soft tissues. The problem is if implant fails, it not only fails, it takes away the bone and the soft tissue as well, and that is very difficult to repair in the future. So the listeners who are doing implant dentistry at this point of time or have been doing it in the past, they would know that bone loss and soft tissue loss is very difficult to deal with. It's very difficult to regain that. So our aim should be we do not let that happen. After the end of this lecture, the delegates should have a better understanding of careful patient assessment and communication. We need to develop this habit of communicating with our patients. We need to make them understand, educate them the importance of plaque control, the importance of looking after their implants. Yeah, getting an implant is not a problem. Looking after the implant is hard work. So please make sure that you communicate with your patients effectively. And that should be highlighted, that should be flagged in your assessment appointment. When the patient comes to you for assessment, any plaque deposit should be a flag, and that in your communication should address that. I know there are some experienced clinicians who are listening to it. There are some new dentists who are listening to it. That may not be a very big thing, but believe you me, this is the first step in developing perimucositis and peri-implantitis. So as I already said, we need to stick to our basics, and then we can build Burj Khalifa on top of it, Empire State on top of it, whatever. But the basis has to be kept in mind. Planning backwards, of which means top down, which means we need to plan our restoration first and then place our implant according to that restoration. Now, all my training was oral surgery based in Pakistan, and then I worked for in the oral maxillofacial departments in England as well. So it was very difficult for me to listen to the restorative dentists I work with. So we're not used to listen to those restorative dentists. So it was very difficult to develop the habit of listening to him. We were used to actually place implants and send the patients to them. Oh, deal with it. It doesn't work like that. In fact, they will tell me where they want that implant to be placed. So the restorative dentist is going to design the restoration first, and then the implant surgeon or implant dentist is going to place that implant, delivering the same restoration, making possible the same restoration. We should consider the factors influencing the treatment outcome. So whatever treatment we're gonna do, it should last. It should have good prognosis. We're not doing disposable dentistry. The dentistry is not disposable. It should serve the purpose. So you need to consider the factors that influence your treatment outcomes or treatment what you're going to deliver. Predictable treatment outcome based on evidence-based dentistry. So let me tell you, please do not record this this presentation at home, or do not take pictures because it's got patient pictures in it, and you do not have the consent to take the pictures. So a wide range of implant-supported restorations are routinely provided today all around the world. So we give crowns, single crowns, we give bridges, we give dentures. All of that is provided routinely throughout the world, and that actually that's where your communication with your patients are going to come in. You need to communicate with your patients, giving them all the options and selecting with them the best option. The word with is very important. It's not going to be you who's going to be selecting the option. It's going to be with them. And we want success, not only survival. So if an implant is there, implant is in bone and it's not mobile, although half of the threads are exposed, yes, 10 years down the line or 10 years before, it may be a success, but not now. Survival only, or the implant is surviving, it's not mobile, it's not infected, and that's it. That's not the criteria of success nowadays. We want it to function well, and we want it to look good as well. So it should serve both the purposes. Yes, it can function when it's not mobile, but it doesn't look well when the threads are exposed. So survival only is not our aim nowadays. It has to be success, which should work well and look good as well. Aesthetic restoration that mimic natural teeth in form and function, so that should be our aim. The implant dentist must select the most suitable, predictable techniques. Now, that has to be discussed with your patients. Yes, I can get an argument of, well, you know, the patients do not know anything. We know what dentistry is, we know what implants are, we know the treatment options, so we should tell the patients. Or there are some patients as well who will give you that authority that you know the best. Okay, deal with it. But I would say, if I am going to actually buy anything from anywhere, I want to know about it. Same is true with our patients. So I think if you put yourself in the patient's clothes, then that will be much more easier. So careful selection and assessment, that is going to be the key. Not all patients are going to be suitable for implant dentistry. So that is very important. So for patient selection, you need to balance this scale. The treatment benefits and the patient factors should balance each other. The treatment benefits can be improved quality of life. So yes, after your implant treatment, the patient should have an improved quality of life, improve functions, improve aesthetics. So yes, it should serve both the purpose. Patient factors. Now, it should be financially possible, financially affordable to your patients. You need to discuss with your patients about invasiveness and extent as well. Some patients may not be happy with zygomatic implants. Some patients may not be able to figure out or able to think about pterygoid implants, or 8 implants in the upper jaw, or 6 implants in the lower jaw. They cannot see themselves as a patient to have 8 implants in the upper jaw, 6 implants in the lower jaw. So the invasiveness and extent has to be discussed with your patient. They may be actually, it's more beneficial that they will have 2 implants in the lower jaw, have a denture, bar supported or locator supported prosthesis, and that's it really. So you need to discuss that with the patient. Oral health and suitability, you need to do assessment of the oral health of your patients. That is very important. Not all the patients are going to be assessed suitable for implant dentistry. Patient factors, how well the gingival look like. Is the patient healthy to have an implant in their mouth? I would say implants are the last treatment that should be conducted. Before that, all the treatment regarding perio, conservative dentistry, restorative dentistry should be sorted. And then implant should be placed in. So there should not be active caries. There should not be any active form of disease before you place the implant, and that has to be very stable before you place your implant. So that's where the patient factors are going to come in. Is this a beneficial treatment? Is this a successful outcome? No, it is not a successful outcome. And the patient should not suffer like that. Patient should not go through another surgery like that. This is the patient who had implants from abroad and has visited us, and then we had to remove these implants. So I'm not gonna bore you with how do you take the dental history. You all are a dentist, and hopefully if any students are listening as well, you should be able to know how you record a dental history. But that is very important. That will tell you, that will help you filtering your patients. As I said, not all patients are suitable for implant dentistry. So we should learn how to say no to our patients. Okay. Any patients who are not going to look after their own teeth, then that is going to be difficult for them to look after the implant. So they should be developed the habit to look after their own teeth first. And then if they can show good commitment, if they can show good plaque control, if their gingival indices are improving, if their perio condition is improving, and that has to be evidenced with all the indices. But just saying the perio has improved is not going to be enough. You need to prove that with your indices. Hopefully everybody understands what do I mean by indices. So dental history has to be thoroughly taken, and that is your domain, or that is what you're going to do. Now, medical history, again, you need to discuss it with your patient. What sort of invasiveness patient is going to have, and what kind of extent of implant dentistry or implant surgery you can deliver. Obviously, a patient 85 or 80 years old want to have fixed bridge, you need to discuss the options of giving them a implant supported denture rather than a fixed bridge. They may not be able to have that much extensive implant surgery. ASA classification, everybody should be aware of ASA classification and medications as well. Now, there are so many medications which are actually keep coming in the medical world all the time, and we have to keep ourselves updated with all those medications. I still meet many dentists who actually I train or I mentor, who will hear a name of the medication and they will say, oh, what's that? So this is not allowed. We need to keep ourselves updated with all the new medications which can affect us. Imagine there are so many. There are some medications which can affect us. Imagine the medical doctors. They need to be updated about, or they need to keep themselves updated about all the medications. We have to get ourselves updated about a small portion. And if we do not do that, there is no excuse to that. So think about it. Do you know all kinds of bisphosphonates which are available in your country? Do you know all kinds of anticoagulants or the drugs which will affect the bleeding? All kinds of them in your country? Think about it. Social history, you need to be careful about the social history of the patient. Smoking, again, has to be discussed, and that has to be put in front to your patients, that if they're going to continue to smoke, then the chances of failure increase. So you need to communicate it with your patients. That is very important. And other dietary habits like betel nut chewing, that has to be discussed with your patient as well. And that is kind of key for all the treatment, not only implant dentistry. Now, are there many contraindications to to have implant placed in a patient? I would say no, not many. There are risk factors, but there are not many few contraindications that will affect your implant placement. So if the patient has got unrealistic expectations, I see patients who actually have not visited a dentist for last 15 years, and suddenly they've got a loose lower incisor, which has been periodontally involved for God knows how many years, and now they want to have it out, and suddenly after 15 years they want it all fixed in 2 appointments. That is not possible. These are unrealistic patient expectations. For those patients, you need to sit with them, because they are never going to be happy, no matter how hard you have worked, because they want it fixed. They think that you've got a magic wand or something. So please make sure that you bring the patient expectations to what you can deliver. Unreliable patient, the patient who's going to have one visit done and then not going to come back. So you need to filter those patients as well. Poor oral hygiene and bruxism and TMD, you need to keep an eye on these aspects as well. The reason I'm repeating all of this is that, as I already said, this is the basics we need to develop our the high-rise tower from. You cannot ignore that one. So this is the protocol we follow. You can take a picture of this slide. So this is the protocol we follow for our implant patients, and we should adhere to a protocol to deliver the consistency of what we call the success. So if we have got a protocol, then we should adhere to it so that we can keep on delivering the successful treatments. And that protocol will allow you to filter the patients as well. So I'm going to go through one by one, each one of them, but this is the protocol we follow. So you need to make sure that you actually go for diagnostic wax-up for all of your patients. You need to tell them what it's going to look like. Imagine you're going to go and buy your house. You've been to a vacant plot, and the architect is going to, by putting his finger in the air, just says, oh, this is going to be your bedroom, that's going to be your drawing room, and that's going to be your dining room. Does it make sense? No, not at all. They will show you a model. It can be a drawing, or it can be a 3D model. They will show you the model and say, look, this is what we are planning to do. This is what we are going to deliver. And that actually breaks the communication gaps in between you and your patients. So please make sure that you tell your patients what you are going to deliver. If you cannot tell your patient what you're going to deliver, then the patient may be thinking something else, and you may be delivering what you can deliver. So there is a huge communication gap if that is not followed. That diagnostic wax can be used to do provisionalization in the mouth. So you can literally provisionalize it and show it to your patient. This is how it's going to look like. Have a look. This is provisionals. This is how it's going to look like. And that's where the agreement is going to be established between you and your patients. Assessment of hard and soft tissues. You need to be very careful in assessing and examining your patients. Implant placement in correct anatomical position. You need to be actually forced into placing an implant into the right position by the restorative dentist. Or if you are the restorative dentist yourself, then put on the hat of being a restorative dentist before you put on the hat for being a surgeon. So that is very important. And by careful planning, you can avoid the damage to the biological structures. Then there is the second phase, and then you do the restoration. So that is how the flow chart for your implant patients are going to be. So I'm going to just show you the pictures of what do I mean by diagnostic wax-up. So it's just a simple mock-up. You can show your patients that this is how your restorations are going to look like, and you get an agreement. So this is all diagnostic wax up, you can see, and that is the provisional prosthesis. So you can show the patient that this is going to the provisional we're going to deliver, so that, and that's the definitive prosthesis. They are pretty much the same. But just literally showing them how it's going to look like after they had the wax up and provisionalization. And up till then, the patient is paying us. So this is a very good selling step as well, that if the patient likes it, then he buys it. But this is not for free as well. Patient is paying us up till then. So even we do temporaries, the patient is charged. You do not do anything for free, because the patient may not like it, and he may go to another place, but he should have paid you for your hard work. I'm not going to bore you with the hard and soft tissue smile. That is what you can do effectively, and I'm going to just point out about the gingival biotype. So you need to mention, or you need to assess the gingival biotype in your assessment. That is very important, because that will affect your results. Hard tissues, I have already, you must already know how to count teeth and how to look after teeth. So I'm just going to whiz through that. Now, traditionally, this was the method that would have told us how much bone is present. Still being used in the areas where CBCT is not that readily available, and I think that will give you some idea of what you are dealing with. Now, there is also an increasing trend of CBCTing every patient. Not every patient need a CBCT. That you should keep in your mind. The patient should not get radiations because you couldn't assess properly. That should not be the excuse. The patient should only get radiations if you have got a certain piece missing in your jigsaw puzzle. The jigsaw puzzle of your diagnosis have got a certain piece missing. That is the only time when your patient will go to CBCT. Or you, by doing these methods, simple methods, 2D methods, you're not sure about an anatomical structure, then you do your CBCT. So please think again before you refer your patients to CBCT. Okay, so this is a traditional way. This is a crude way of seeing how much bone you've got. That is some OPG and a 2D way of seeing what you're dealing with. So it shows the maxillary sinuses, the ID canal, and that is where you can do most of your assessment. The only aspect which is going to be missing is your buccolingual width. And that is where, if you think that buccolingual width is that important, without that you cannot carry on, and that is your missing link in your jigsaw puzzle, then you should go for your CBCT. 2D X-ray, I would still say, if you do this 2D X-rays with proper holders, with proper technique, this still gives you a lot of information, But if your X-rays are crap, they are not good, then you cannot have that information from those X-rays. So use your conventional methods, and if you want to do CBCT, by all means, but you should have a justification for that. So these are the methods you can do for the assessment of hard and soft tissue. You can definitely go CBCT as well. So you need to consider what has happened, why the patient has lost teeth. That will give you an idea about your hard tissues. So everybody knows about how do we lose bone after exodontia. I'm not going to go into detail. Now, as a clinician, you should tell your patients about the assessment of remaining dentition as well. It's not that you're going to place an implant in upper right 5 and you do not care what happens in upper right 6. So you need to give the patient the assessment that what is going to be the prognosis of upper right 6. Then there is guided surgery as well, which is by all means available to everybody nowadays. And make sure that I do quite a lot of guided surgery, but I still raise my flap. I cannot take the risk of actually going flapless with guided surgery. I've seen failures. Yes, we can go flapless with guided surgery, but all the pieces have to fall together in order to have that precision. If any of the link is missing, then the results are not going to be the same. So you need to think about it. All the flow chart, all the flow sequence of events should be the same, or should be done with that precision. So this is a patient we did on the upper left, 4 and 5. So this is the pre-op CBCT. That's some other views. And that's the planning which we did. So we placed the implant. We placed virtually the implant. This is the guide we got for our implant placement. And that's during the surgery, as I already mentioned, that I do raise the flap to see what's happening, and that is pretty much what was shown in the CBCT. We've got a fenestration. So we have placed the implant, and so guided surgery, stent was placed. You can see the stent has to be effective. It has to be very immobile, and it has to. So that is the implant placement, and the bone grafting was done around it. So it's an immediate placement with the guided surgery and stent. Soft tissue, you need to be aware of the soft tissue gingival biotype and the status of your soft tissue. That's a rough guide for how many implants you're going to place for how many teeth. You need to be careful about the spacing. Not all the space needs to be filled. For example, this space, look at this space. It's a massive space to be filled. You need to plan in your mind what you're going to do with this big space. Are you going to place 2 implants? If you're going to place 2 implants, where would they go? Narrow spaces, you need to plan for that as well. So a simple guide can be used as well to place the implant. You need to be very careful how you place your implant. You can see that this implant is literally placed where the bone is, not considering about the restoration. Uncover the gingiva should look very healthy, keratinized, all healed up when you uncover. Nowadays we uncover with very less invasiveness, and provisional restoration should be planned in advance. These are some of the examples of provisional restorations. Definitive restorations should be delivered, and they should mimic the provisional restorations. They should be very much same the provisional restoration. And you can see post-op results, 5 years, there should not be crestal bone loss, or the implant should look very good. You need to be very careful about your cliff edge ridges. So what you're going to do with that cliff edge, this is a patient we had to place a mesial cantilever. Crestal bone loss should not happen. It should retain after 5 years. That should be our aim. This is a pre-op picture of a patient. You can see there's a dip, buccal dip. That's the pre-op x-ray. The bone height looks pretty much good, but there's a problem. There's a big crater, which can be dealt by having implant placed straight away, or bone grafting and then delayed implant placement. In order to achieve predictability, we chose the later way, which is bone grafting. And this was the bone graft done, and that's the suturing. You can see the pre-op and the post-op picture after grafting. The pre-op will show you the crater, and the post-op will show you a bulge. So that is how the implant is placed precisely, and these are the results. Another case, you can see a retained root. This is a young chap. He should have very good results, because he cannot have bad aesthetics in front of his mouth. So he cannot have a bad implant in front of his mouth. So these are the radiographs. That's a provisional restoration. Implant is placed, and these are the results after 5 years. So you can see no gum recession, because have a look at the gingival health. Have a look at the overall health. Look at the plaque control. This is all a package. The predictable results, but everything has to be looked into, what we discussed initially. This is a very good case of socket preservation, what we normally do. So the patient had to lose number 6. So we took number 6 out, pushed up the floor of the sinus, grafted it, membrane, and you can see the beautiful results after grafting. And you can see in the x-rays as well, quite a good bone height has been gained. Implants placed, and these are the final pictures, and these are the post-op pictures. So if done predictably, they should give you results. This is the patient which has had he has been coated a block chin graft, which he declined, and he wanted us to do the surgery with the normal particulate graft. You should not underestimate the power of the particulate graft. Look what we have done with this patient who had a massive bone loss and was coated a chin block graft. So look at the bone loss. So did the grafting, GBR, placement, impressions, and look at that. That tip is gone. That has been corrected. These are the provisional restoration. So from here to there, this is corrected with a particulate normal GBR. So do not underestimate the power of the GBR. 3 years results. We do quite a lot of mentoring and coaching, and we conduct courses all around the world. This is our course. On the left hand side, you can see the course which we are planning to do in England. It's a postgraduate diploma for implant dentistry. That will be of 19 days duration. On the right hand side, you can see the digital implant dentistry course which we conducted, and we're going to conduct more of them with next level dentistry. And so I will give you my email address. Sorry, we do not have much time for questions. It was only a 45-minute slot, and I'm off to play cricket after this. So this is my email address. Please email me. I'm on Facebook as well, Instagram as well. So message me, contact me by all means, and I will reply to you as soon as possible. For those who are all over the world, stay safe. It's still there. Pandemic is still there. So please stay safe. And any questions or any queries, any guidance, please contact me. This is my email address, and I'm on Facebook and Insta as well. So thank you very much. And I've just finished on time. Thank you.
Thank you. Thank you so much, Dr. Kashif. It was a very informative session. Now we'll move on to the next session by Dr. Reem Shafi, and it will be broadcasted at 3:45. Thank you, Dr. Kashif, for joining us.
Thank you very much.
Thank you.